Good evening, everyone. Thank you for joining us for a special version of State of the Virus. I'm George Stockberger, and we have a panel here for our 1 year in review for COVID-19. Joining us today, of course, Dr. Michael Scalzone, Chief Quality Officer from Guthrie, James Nobles, the CEO of Laurel Health, here helping us represent the Northern Tier, and joining us for the first time on State of the Virus is Ken Herzl-Betz, the Chief Medical Officer for Arnett Health. So again, all of you, thank you for joining me. I want to start with you, Michael. We're talking about the 1 year of COVID-19 in our area. Can you kind of take us back to the first time you heard about COVID-19?
Boy, that seems like a long time ago, George, but I think we all remember it pretty well. I think it was dribs and drabs in the newspapers, right? We were hearing on the radio of potential infectious disease, other countries, other states. I actually was traveling down in Florida when they really first began to have cases up in New York. And so I can remember wondering in late February, should I travel, should I not travel? And by the time the first week of March rolled around, we were on our way back, and shortly thereafter, everything began to change. And so I think the rapidity of change in the beginning, how it went from something that didn't seem to be impacting us very much as healthcare systems to really exploding in our awareness, changing how we worked day to day, was really dramatic back a year ago.
I remember it very similarly. I also had been traveling just before that. I think I first heard about it in January, and then in February, we were getting reassurances both from the CDC and from the president at that time that they thought it was under control in Wuhan, and it really didn't hit the fan really until we started hearing about cases in the US, and I think that was late February, early March. So, and that's when things shifted very dramatically. So at least at our hospital, we had frequent meetings starting early, actually late in February. We were meeting on a daily basis to talk about how to plan for this, how to prepare for it, and realizing that things that we would like to get were not available easily. So things like PPE, so the N95 masks, the gowns, the gloves, anything that you can imagine that would be necessary for a pandemic, the entire world was looking for it. So it was very difficult to get a hold of it. And we started considering what can we do to protect everybody so that our staff don't get sick and so that the patients coming into the hospital get sick. So we practiced, studied what the CDC was putting out there, what other hospitals were doing, and there was a lot of reuse of masks by the same person during the day. So instead of getting a mask every time you saw a new patient, you kept one mask the entire day. Same thing with the N95s. You recycled those, kept them in a safe place, and then used them intermittently over the next week. So it was a dramatic change and major change in the process for both nurses and for doctors.
Yeah, George, you bring up an interesting point there. I think all of us will remember, much like we do with any event around the country, where were you on the day when you heard about this? You heard Dr. Scalzone mention he was traveling. I still remember it was very early February, and we kind of heard about this virus that was coming out. We didn't really know what direction it was going to travel. Our infection control team and our risk manager sat down in one of our quality meetings and said, hey, we got to start dusting off our protocols. We got to start looking at our pandemic protocols again. And we're all kind of scratching our heads saying, boy, is that really necessary? We're being told by the government and the experts that it's really not going to affect us here. But all three systems have great teams. I've worked with all of them very closely, and really to have that team come and push you in that direction and say, no, we need to start dusting off our protocols. We haven't had anything like this ever really affect us before. We've had some Ebola scares, the H1N1, but nothing to this magnitude. So reviewing policies, getting our staff trained. One of the things we did very early was really start making sure everybody was fitted properly for their N95 face masks. We talked a little bit about that already, and it was so important. We don't necessarily see these in the outpatient practices that Laurel Health has around the areas we serve. We don't necessarily have our staff matched to that protocol on a daily basis. So really getting them in, getting them fitted, and then really starting to figure out where we're going to stockpile personal protective equipment. We have to protect our healthcare providers so they can go forward and provide that care to the patients that we were anticipating. So It's been a very, very challenging year. In some aspects, I look at it and say, boy, it was really just a slow grind every day, a lot of 14, 15-hour days. But now that I look at it in retrospect, it's like, wow, it's already been a year. We're coming up very quickly on the first positive patient in Tioga County here at the end of the month. It was kind of March 25th, March 26th in that time frame when the person was admitted to our local hospital, and then the diagnosis came out. So it's really hard to believe where we were a year ago and where we are now.
And the other thing I think all the systems did was we developed very quickly ways for the public to get in touch with us. So we updated websites, we established phone lines for people to call in. Testing was really short, so we had to be very careful about who we sent for tests. And then to protect the PPE, we also had to identify where you want to send people who are symptomatic. So we narrowed it down to just a few clinics and the emergency room. And that really seemed to help protect everybody else. You don't want sick people mixing with people that are healthy as much as possible. So
I think we learned a lot about communication, and of course, through the media like this, George, how we got messages out to the public that we wanted them to hear that were important for their safety, how the public could get a hold of us, and how our communications team would help get that right information out to the public. Very different type of communication than we usually do with more standard healthcare messages. This was very different. It was more immediate. It was more multi-channel. And I think that was a learning for us all, or at least I'll speak for us. It was a learning for the opportunities that we had, that we could effectively get messages to the patients, particularly to maintain important care. So we know that there were some delays that happened early on, that people were afraid to come to offices. Ken mentioned being communicative and having safe places where patients could come to get that care. And I think that was an important thing that we did early on.
Yeah, we had a
Well,
lot
I think, Mike, you bring up a great point. In that communication piece, the public looks to us for the answers. We're the healthcare systems that provide their care. They want to be able to trust us. I can't tell you how many times in different meetings at the county and state level, we would have to say, this is a novel virus. And we had to fill in with a lot of, we don't know, or I don't know. The information was changing. It started weekly, then it was daily, and then at some points even hourly, where the recommendations were changing at the state and national level. Department of Health were quickly overwhelmed. We were looking to them for answers, and they were turning to the CDC, and it was a very challenging time. But I think through it all the systems here really demonstrated that professionalism and that calm that all the patients have come to trust on both sides, Southern and Northern Tier, that our patients have come to trust. And they could turn to us, and if we didn't have the answer, we certainly worked as hard as we possibly could to get the answer and demonstrate that sense of calm so that they knew we were here for them. We're here for you. We're going to take care of you. We may not have the answer now. We're working with our officials to get it, state, local, and national. But that certainly was a challenge, as you pointed out, Mike.
Yeah, ARNet very quickly also switched to telemedicine. I know the other groups also did the same thing. So a lot of visits with patients, instead of having them come in order to keep them safe, we were doing it by Zoom and other similar kind of programs. So I think that was a major change in the way that we provide healthcare. The other thing that we did is, so ARNet did contact all of the nursing homes in our region, and we discussed the mandate that the governor had put out about potentially sending patients back to the skilled nursing facilities after they had been hospitalized with a COVID diagnosis once they no longer required acute care. And the feedback that we got immediately was that, no, you guys need to hold on to those patients and not send them back to us. And we did honor that. We kept as many patients as we could in our hospital for as long as we could until we were sure it was safe to send them back. And I think as a result of that, most of the nursing homes in our immediate region in Chemung County did really well. I think there were very few outbreaks in nursing homes. That changed later on in the year, but at the beginning, I think there was a great collaboration to try to manage that. So.
And I think those are three important points right there of things that will forever be a little bit changed because of this. Telemedicine is something that certainly is expanded more than it ever was, and I don't think any of us can see that changing. That sort of preparedness that, Jim, you talked about, I think we all have going to focus a whole lot more about what might be the next challenge to systems. And so I think that is something different about how we'll have our daily work. And then the collaboration, Ken, you said talking to your skilled nursing facility partners. And I think that collaboration between healthcare systems, between local health departments and healthcare systems is just much more robust than it was a year ago. And that can only be good for the communities we serve. That's a positive in any way that we look at it. So, as we try to find silver linings in this, I think those are 3 points right there that are things that we'll take forward as a better than in 2020.
Yeah, I don't know your thoughts as physicians. I look at this and I think we've really advanced telehealth technologies probably close to a decade, at least half a decade. I mean, we were moving in that direction anyway with the urgent cares. We see the younger population wanting that smartphone technology, being able to get care really from using technology to their benefit. And as we moved in that direction, it was very important, but we were slow, and the payers were slow to adopt that. CMS wasn't on board, and getting them on board was instrumental in driving that. And now we see that as an integral part of our daily care delivery model. Telehealth is going to be here to say we've realized we can provide great high quality medicine to people, and they don't necessarily have to come out of their house and expose them to potential other germs and pathogens coming into the office. And the other thing I think that changed, and you guys can comment on, we're one of the few sectors we build waiting into what we do. Everybody knows about a hospital waiting room or a clinic waiting room. It's factored in. When we build or we purchase a new building to reconstruct in the healthcare office, we start to look where can we put all our patients to wait? And we've realized that they don't necessarily have to sit in a big open room. They can do that from the safety and security of their own vehicle, listen to their own radio, and we can call them in when we're ready. And I see that as a major change moving forward, whereas we look at these structures and Mike, with the building up next to the hospital, trying to factor in where waiting isn't part of the process, moving patients through the visit. I think that's forever going to change for us in a positive way.
Yeah, no, that was a major plus, not having patients sitting there waiting to come in for the appointments, and just having them move through and be roomed as quickly as they came in and exit quickly also.
So going back to the first couple weeks of this and months of this, of course, we're all just right on that Pennsylvania-New York border. And Michael, I want to ask you, what was it like dealing with New York and Pennsylvania at the same time, having hospitals in both of those states?
Yeah, I can see my colleagues on the call here sort of just nodding their heads saying, glad it was you and not us necessarily. It was a significant challenge. In the best of times, it's a challenge to have 2 states, and quite frankly, 2 very different states in how they regulate healthcare. But the changes were frequent, and they were often in different directions. And what we found is both states had some strengths in how they handled this, and both states had some challenges. And so it remains even today as we deal with vaccine distribution. Very different on 2 states, from eligibility, from distribution, from documentation, and how scheduling goes. And so it really has been a challenge. But what's most important is taking care of the patients is the same. So no matter where your hospital is, no matter where your facility is, the patients are still looking for high quality care. They're looking for patient focused care. And I think that's what everyone on the call here delivers. But it would be simpler if we were in one jurisdiction, no doubt.
Well, I think it was nice, George, to your point, we did see the governors of New York and Pennsylvania agree, and other states as well, the 5 states in this Northeast area. They did agree to work together as much as they can. As Mike pointed out, there's difference in the states, there's difference in how their Department of Health are staffed and manned. So there were subtle nuances and differences, but I think the overall strategy of the states was very similar. And we saw some similar restrictions as they were imposed. We saw them kind of overlap, which is good. For us, it doesn't really affect downstate. You get south of here, Harrisburg and Philadelphia and Pittsburgh and things like that. They don't cross over, but our residents cross over. We have a lot of people that live in Pennsylvania and work in New York. We have businesses, like Mike pointed out, that have hospitals on both sides. Laurel has a whole string of health centers right on that New York state border. And we have a lot of our patients and families that we serve that actually work at Corning Incorporated, but they live on the Pennsylvania side. So it was nice to see the states work together in that collaboration and really pull together and try and align their processes and policies as best they can. But now that we look at it in retrospect, you know, if we could combine the best of both, we'd be in a lot better spot. There was some stuff that New York did just great, and Pennsylvania fumbled the ball. And there were some times when we scratch our head and say, "Ooh, I'm glad we don't have any clinics in New York State because it's getting a little dicey up there."
Yeah, no, the travel restrictions in New York State were a big worry for us. The governor was very proactive in trying to limit the influx of new COVID cases into the state. But as a result, one of our worries is that a lot of our workers do come from Pennsylvania. A lot of our patients come from Pennsylvania, and restrict them from, you know, coming into the hospital or being seen in the offices was a big worry for me. I was glad when they said that any contiguous state is okay to travel back and forth. I was not sure how we were going to staff if we didn't have that permission to do that. One thing that's still frustrating for me, though, is that in New York State, you know, we can vaccinate workers from Pennsylvania, but we cannot vaccinate patients from Pennsylvania. And that's very frustrating for us because we want to serve our patients even if they live across the border. But I guess because the vaccine's being distributed based on states and based on populations within those states, New York doesn't want to share at this point. So.
All right. So again, we've talked about a lot has changed since this pandemic has begun. We talked a little bit about how telehealth has changed for everyone at this point. What about some of the treatments? I mean, again, thinking back to last March, you know, every week it seemed like there was a new miracle drug that was out there for coronavirus. So how has the treatments kind of changed? And we can start with you, Ken.
Well, initially it was just supportive treatment. So we learned that you could position the patients, you could do a thing called proning that helped with some of those patients. And initially people were fairly quick to intubate patients and use artificial ventilation for them. But as they studied this longer, they found that maybe it's better to wait on intubating the patients and use high flow oxygen and things like that. And then we started getting drugs like remdesivir and other things that we can give in the hospital. And then the monoclonal antibodies that are available both for outpatients and inpatients, and as well as the steroids. So it did change a lot over that period of time, but supportive care is still a big piece of it. So.
And
I
then
think we learned that in a rapidly changing situations, treatment changed quickly as well. You know, traditionally in medicine, we like very detailed, robust, randomized, controlled, double-blind trials that have had thousands and thousands of patients in there, and there's just no time for such things in a situation like this. And so there were some trials, and there were some things that were used in the beginning that were found to not be effective. So, you know, I think we all know some of those examples. And so we were able to try them, and if it didn't work, move on to the next. I think Ken brings up an important point. A lot of this truly was supportive care rather than any miracle medication. You know, it was about strong nursing care. It was about having physicians do consistent practice. And it was about good, important hospital care. So I think that of all the learnings, it's not about therapeutics necessarily. It's not necessarily about, you know, a magic drug that's going to help people do better. What we're really learning about is the vulnerable populations. You know, it really points out who's vulnerable, whether it's those with disparities, whether it's age-related or medical comorbidities. What we've learned is that there are some diseases that are just terrifically different in a different population. And we knew that, but I think this really points it out and how we have to protect those populations.
Well, Mike, you and Ken bring up a great point. You know, that supportive care, and that's what we talked about so much in the beginning, was not overwhelming or overrunning the capabilities of our healthcare system, so we can have that proper nurse to patient ratio, so that we have that, you know, 1-to-1 or 3-to-1 or whatever the ratio numbers you have for your specific systems are, so that nurse can be there for that supportive care. As the numbers shot up and hospital systems quickly became overwhelmed and resources were stretched thin, I think that's when we saw the outcomes going in a different direction. Now, we were a bit protected up here in the rural communities early on in the virus, when other states were getting hit pretty hard. New York, Ken, as you know, specifically New York City, where the death rate shot up very quickly because we didn't know how to treat this, and they quickly became overwhelmed. You know, that was one of the areas where our rural community was protected, And we really didn't see huge influx of that back in March and April and May. And then of course, as the weather turned nicer, people spread out. But that was a challenge for us. We would get a lot of questions. And one of the things we were shadowboxing with was there were press conferences every day in the beginning. There was a lot of information being pushed out to the general public. Dr. Google was involved. Anybody can go home and Google something and they're all of a sudden an expert in medicine and come in and try and explain to you, how they want this therapy and even so far as to demand it. But Mike, as you pointed out, we like safe, we like stable. We like to say, look, this has been tested and retested and double blinded, and now we know it's going to work. And just because you heard it on TV or heard it from a trusted official, it may not be in your best interest right now. And that's one of the things we always profess, all the systems did, we have to follow the science. And the science has led us in some great directions. We have some great therapies on this, as evident by the fact that our case numbers could continue to go up, but our death rate remained much lower than we saw even early on in the disease. And that's a testament to our ability to develop these drugs quickly, test them, and get the therapeutics out. So I think we're in a much better spot moving forward.
I think the other big shift that was hard for hospitals and hard for patients and families alike was that most of us restricted visitation at some point. The nursing homes were definitely required to restrict visitation, and that cuts you off from a lot of support for the patients, and it also cuts you off from information for people who really are in bad shape. A lot of these patients who are coming in were elderly patients who were in such a bad state that they could not speak for themselves. And it was a challenge early on, trying to get the right information, trying to make phone contact with families and trying to be supportive of families, despite the fact that you had to keep them out of the hospital. That was not a situation any of us were comfortable with.
So again, right now, we're still in the middle of this, but we're coming out of it. So for anyone, again, still kind of looking back at the beginning, what are some things that we learned since the start of this, where if we could go back, we would change something? Of course, in New York, a lot of issues with the nursing homes going back and forth, like we talked about before. Is there anything that, looking back now, we thought, I wish we had done this a little bit different?
Yeah, I think there's always an opportunity for lessons learned, and it's very easy to Monday morning quarterback this. The mixed messages in the beginning were very challenging, and I think we fumbled the ball a little bit in the beginning. Let's go back to the masking. How many times did Dr. Fauci, the Surgeon General, other departments of health saying, no, you don't need to wear a mask. It doesn't do anything to, it's not small enough to filter out the microns of the coronavirus. And then we came back several weeks later and said, oh, no, I have to wear a mask. My mask protects you. Your mask protects me. And that was very challenging. That was a challenging message for the healthcare system to be able to reiterate that to the public and get them to trust us and say, nope, this is in your best interest now, even though we told you something different a few weeks ago. And if we could go back and change something, consistent messaging is going to be very important. But as I said earlier, it's a novel virus, it's a novel disease, and it's okay to say we didn't know. We're learning it as fast as we can. And when we look at where we are now, 1 year later, light years ahead. If this was any other time in history, it would have taken us many years even to get close to where we are now. And we're light years ahead of where we were just a year ago.
I think that testing and contact tracing is the other thing that would be very helpful if you could do it early on, and as well as the masking. I think all of those things would have slowed the spread a lot and hopefully would have contained it a little bit better than we did. And that was the sad part. And as Mike said, there are certain populations that we now know are extremely vulnerable to this. So people over 65 who have chronic health problems, overweight, breathing problems, hypertension, diabetes, they really need to be protected. So being especially careful around them is important.
All right. So again, we talked a little bit earlier about telehealth as one of the things that we're going to keep going forward as we go into what we've all kind of called the new normal. Are there other things that are just going to make us a healthier society, whether it's the hand washing, the sanitizing, and not just hand sanitizer, but we're cleaning buses, we're cleaning planes, we're doing all this stuff now. So what are we going to kind of keep from this period, and how is it going to just make us a healthier community?
In my mind, the fascinating part, yeah, is when you look at influenza. Influenza usually hits this area pretty hard, and it really didn't this year. I think partly because people were keeping masks on and staying away from one another. So I would hope that people would do a better job of cleaning and being careful with distancing and things like that when there are these infectious diseases around. So.
Yeah, I do think that's something that will definitely make us healthier. And I think we've opened up conversations about underlying health conditions, and I hope that continue. We do know that, from a public health standpoint, there are just some behaviors and medical conditions that put people at risk, and those are hard conversations as physicians we have every day with our patients. And so, having a pandemic and the stress involved actually made some of these more difficult rather than easier conversations, but hopefully it opens the door to say, those are behaviors or medical conditions that need to be taken care of, and it will help should another event like this occur. It's really important from a public health standpoint.
Well, and even more so, like you said, Ken, we talked to a lot of patients, and even my family included. We didn't get our normal winter cold. We're coming out of the winter months now. Spring's right on the horizon. Normally we all get affected by just the common cold once a year. And I've had a lot of patients say, boy, we must be getting healthier. And it's no, we're not in contact with everybody like we were before. And then you brought up some great points. I serve on one of the local school boards here for Southern Tioga, and our disinfecting protocols for all of our public schools have increased dramatically. Everything's getting wiped down multiple times a day. You guys know, having delivered a lot of babies, they're quite the spreaders of germs throughout their young lives. They're not really good. My son's 18 now, and he's still not great about washing his hands, despite hammering that in his head over and over. Younger kids are the worst. So schools were a vector for a lot of these common colds and illnesses that went around. Our pediatrician has made comments that he's kind of sitting around twiddling his thumbs a lot of the time here because we didn't see that influx of just sick visits throughout the tail end of last year and even into this year. So I think some of that will probably continue. I think we've hammered into the public pretty hard. What our parents and grandparents told us is true: wash your hands before dinner. Now it's wash your hands multiple times a day. And we can probably prevent a lot of these common colds from reoccurring in the future.
Yeah, I keep on wondering if the building standards are going to change. As you look around, all these people have those protective barriers around now, the clear plastic barriers. So I'm not sure if they're going to stay or not, but they do make a difference. And I've become very aware of air exchange and how quickly things exchange. so it clears out vaporized excretion. So. Mm-hmm.
Yeah, and God forbid now, Ken, that you cough in public. I think we've all found ourselves.
Yeah,
you're gonna tickle in your throat. You're like, I don't want to cough. I've got to sneak off where nobody in the store can see me, so they don't, so they don't throw the net over me and pull me out. So I think we are very aware of that. I think we're very aware of distances as well. That kind of that social distancing thing that we really hammered hard. We used to pack people into a lot of close environments. Even our travel industry, our entertainment industry, people were just pushed together. Even our waiting rooms as healthcare systems, our chairs were never spaced out. You could be sitting right next to somebody who's in a clinic who probably could be there for a sick visit, could have a very, contagious illness, but they sit out there right next to somebody who could just be getting there for a routine physical. And I think we're very aware of the social distancing requirements, and that's something I see us continuing with, spreading people out, even if waiting rooms are here in the future. Who knows? I think we've come a long way with spreading people out and realizing we don't need to pack them into small areas.
All right, so I want to talk a little bit about the vaccine. When the vaccine first kind of came out, or again, going back to April and March, people were talking about a vaccine in 2 years, maybe even a little bit longer, just because the process for developing a vaccine was incredibly time consuming. So now that we've created all of these vaccines, all of which seem to be effective, what does this mean for the vaccine process for diseases that we've been fighting for years, like HIV and AIDS, or even cancer at some point? Are we going to start seeing more vaccines at some point for diseases that we've been battling for decades or even longer?
It's a new technology, the mRNAs, and I don't want to steal anybody else's thunder, but it looks like they can develop vaccines much more quickly with the mRNA vaccines, and it can be very specific. So literally, they can target a part of the virus that we know is not part of the human body and make the antibodies against that part, and then protect you from the virus and not hopefully trigger the autoimmune diseases that a lot of natural infections can trigger. So go ahead, Mike, you were going to say something.
Oh, no, I agree. I think, you know, technology doesn't move incrementally. Sometimes it comes in leaps and bounds. And, you know, if we're very, very honest about this, you know, dollars matter, right? So this was financed. This was financed. People began looking at vaccines against coronaviruses back when SARS, the first SARS were, and they began to develop it, and they had the technology in mind of how they would go in that direction. But that epidemic faded away, and there was no business need for them to continue. But when you put a lot of resources behind something, you can make a big difference, and I think that's what happened. And there's no judgment in that. It's just reality that it takes a lot of time, effort, and money in order to make these kinds of advances in healthcare. And so hopefully we'll continue to find the financing available for that, because all of us as healthcare systems have certainly had to deal with the financial impact of this pandemic as well, as the rest of our community has.
Yeah, it was
George, I think it's real important to point out as well. Sorry, Ken. I think it's real important to point out, we talked about this in the last segment I was on, the technology used, the process used, it was still the same rigorous FDA approval process. They did get emergency use authorization, but the vaccines have been adequately tested. They went through very, very rigorous phase 3 clinical trials, human trials, you know, as Mike said earlier, double-blinded, placebo-controlled trials. And the vaccines are safe, they are effective, but we did develop them at a very fast pace, which was great. We needed that because our population was really pushing us hard to return to normal. We've all heard that, you know, many, many times. When are we going to get back to normal? And we don't know what that new normal is going to be. But I do want to stress the importance of the fact that when it is your turn to get a vaccine, as your viewers watch this, they can do their own research, do their own diligence behind this. But when it's their turn to be vaccinated, they can do so with a high degree of confidence, as these went through rigorous testings. The FDA reviewed them. They had a panel of physicians and public health experts that reviewed all the findings from the pharmaceutical companies. They then voted on that, elevated that up to the FDA to grant that emergency use authorization, reviewed again by the CDC. So they are safe, they are effective, and they are what is going to help us get back to that new degree of normal that everybody so much desires.
I agree. And it wasn't all de novo research. It was research that had been done for 10 years. As Mike said, they started it after the initial SARS infection, and they also developed it in response to Ebola, trying to figure out ways to prevent that. So there was a lot of research that went on. Yes, it was developed quickly, but it was on the back. It stood on the back of a lot of research by scientists for a long time. So I agree with you, Jim. It's a very safe vaccine from everything that I've read and everything that I've seen with the patients that have received it. So a huge number of patients in our region have already received the vaccine and done really well with it. So I think Arnott's given out 20,000 vaccines at this point. So we're very close to it. So.
Yeah, Mike, as you said, you know, I'm really anxious to see if we can get that funding and that support, you know, both from the local, state, and federal level moving forward to push the pharmaceutical companies to continue to develop vaccines for other illnesses in a more rapid format. You know, prior to this, you know, the quickest vaccine rollout took many, many years to get through the trials. You know, we did this in really, you know, under a year, right about a year, give or take. And, you know, we really hope from the healthcare sector that we can continue to get that funding at the national level to help these companies develop these in a rapid format. We're going to save lives and we're going to make people healthier.
All right, so again, we're still in the middle of a pandemic, and there's things that we are still learning. So this one, both from a health side and a societal side, what are going to be the long-term effects of COVID-19? Again, we're still learning on the health side and also on the society end. But what are some of the things, and we'll start with you, Michael, what are some of the long-term effects of the virus at this point that we can see?
Well, one of the things that as healthcare entities that we've learned is how fragile our supply chain is. that it is very easy to have an interruption in our supply chain that prevents us from being able to deliver healthcare. We learned that with PPE, we learned that with testing supplies. And so that actually is not something I think day to day any of us really thought about much, impacting the care we deliver to our patients. We learned very quickly how that could change when there's a international demand for those supplies. So I think that is something that we've learned on the healthcare side. From the societal side, I think that healthcare workers have recognized the support of the community. And I think the community recognizes what healthcare workers are doing for them. And that really is very rewarding. The gratefulness of the patients and the community for the work that our teams have done has just been really something to watch. And so I think that's something that has changed and a learning that we had from this.
Well, the word hero has been thrown out a lot. You know, we hear that a lot in the healthcare sector. We don't require thanks for what we do. It's why we got into this. We have compassionate souls. We have to care for, and we want to care for our fellow man, our patients and those we serve. And it was very humbling to see. It was very humbling to see the community rise to that. I saw a response to that as a military veteran, you know, after the first Gulf War, coming back from that, and the response seen by the community, you know, everybody praising military people as a hero. And now we're recognizing the healthcare sector for the heroes that they are. These people just give so much to their patients every day. You know, everyone on this panel here could attest to, you know, nurses staying after pulling double shift, you know, physicians missing times in their families' lives, significant times, children's birthdays, anniversaries, stuff like that, because they had to stay on the floor that extra time to care for a patient. These are the heroes, that frontline healthcare worker that's going to spend that extra time just holding a patient's hand, as we talked about earlier, because they can't have visitors. They couldn't have visitors when we were trying to really limit who could come into our healthcare setting. And to see that reflected in our society is just, it's overwhelming. It is. It's great to see the society rise to that and recognize healthcare workers for the heroes they are during this pandemic.
And we saw the same thing too. We had nurses who, as you said, worked many extra shifts just to try to make sure that everybody got cared for. There were a lot of times when we were short nurses and we were short doctors, and everybody just filled in, pitched in. So those individuals were really important. And they were risking their own health, and they were risking the health of their families, and they were very aware of that. But as you said, this is the job. This is what we do. We're here because we want to take care of people. So it's really important.
Yeah, I'm so impressed with the team, you know, and I'm sure you guys are as well. The word no never came out of anybody's mouth, except it was, you know, do you want to go home? No, you know, I'll stay as long as I need, you know, and that was really very humbling as the CEO of a health system to see that kind of support and dedication. We know we have a great staff, you know, we reward them many different times throughout the year, but it was really awe-inspiring for me to be part of such a great team, and really all the systems, to see how we pulled together as one cohesive unit, caring for the populations of the counties that we serve. It was really awe-inspiring, and I'm humbled just to be in the presence of such great physicians.
All right, so the title of what this whole special is Lessons Learned. So I want to go to each of you. What are some of the lessons that either yourself or you think the healthcare system or the world at this point has learned as we are slowly coming out of this pandemic?
Well, I'd say we're better together is probably one of the biggest lessons, whether that's inside our own organizations or working together as organizations across the community. We do a better job when we collaborate rather than when we compete. And so I think that was definitely a lesson. I think, you know, Ken touched on this earlier when you were talking about the challenges of not having visitors. The importance of social connection is just critical, and we see that in our communities, and we see the mental health issues that come forth because of folks that are isolated, and we see that particularly in vulnerable communities like elderly. But we all need that social connection, and I think that's part of what Jim is talking about, how people would rally around during those difficult times and help one another as colleagues. So I really think that community sense is a big part of what I've taken away from the last year. That's something I would never want to give up.
I was going to say for myself, I've learned that we really need to think about infectious disease as a global issue because it can travel around the globe very quickly. So taking care of people in other countries and keeping these infections isolated as much as we can is really important. At the same time, it's important that we not only that we develop our own resources for PPE and medicines and things like that. I think the US has done well at this time because we really ramped all that up for this country. That's why we're getting out more vaccines than a lot of other places. And it's why pretty much once we got going with the pandemic and we realized that there was PPE that was needed, we did develop a lot of ability to produce those things in this country rather than relying on China and other countries. So I think that balance of recognizing, we need to collaborate together, but also developing our own resources is important. And I really appreciate the support that the other hospitals have been given. We meet weekly with all of the hospitals in the Southern Tier to discuss how we can collaborate better. So.
Yeah, I think we can't understate the importance of really, George, just planning. We have to plan, and we have to train. We weren't complacent by any stretch. The healthcare sector's always remained on the cutting edge. But obviously our focus is shifted in other areas. And when this was cropping up, as I said earlier in the segment here, I still remember the infection control team coming into a leadership meeting and saying, hey Jim, we've got to start dusting off our pandemic protocols. We hadn't looked at them in several years other than our annual review to make sure they're up to date. But the planning aspect of that, we really rolled our sleeves up very quickly and we planned for the worst. Our rural community was spared of that through the early stages of the pandemic, but we were planning, we were consolidating healthcare systems, moving clinics so we could have better support. We really had to understand more what happens if our healthcare providers become infected. How are they going to dispense care if they too are sick and they need to be home or in the hospital convalescing? So the planning aspect of this, I think we're much better. We can pivot a lot quicker because, as I said, the information was changing at some points, even hourly. It started out with, this was the forever 2 weeks. 2 weeks we're going to be done, and then it was 2 more weeks, and then things were changing daily and then hourly. We've got to the point where we can pivot very quickly and modify our plans, but we have to be on the forefront of that, looking ahead to what the next pandemic is going to be or what the next thing is going to plague our healthcare systems and prepare them for that in advance so we don't get caught off guard or flat-footed, so that we are ready to pivot quickly. We did respond very well, but there were a lot of challenges in the early stages of this with trying to pull all the resources together, the PPE limitations. Testing was very challenging in the beginning, and we would have liked to see that roll out a little quicker. There was, it almost seemed like a lottery system if it was at some points to get a test, and people were traveling all over different parts of our region, even out of the state, both New York and Pennsylvania, just to try and find a test somewhere. We tackled that. And now we're seeing some of the similar concerns with the vaccine as that rolls out. The public wants this, they want it quick, and we're rolling it out as quickly as we can, but they're getting frustrated and saying, hey, my brother down in this county in Philadelphia got his quicker. What if I drive down there? Or can I drive up to New York? Or can your people drive over here? I think that planning stage would prevent a lot of that and help us pivot quicker.
The other thing that we had that I expect that the other groups did too was we had a lot of ethical discussions about distribution of scarce resources. And I think that prepared us, none of us wanted to face that scenario where we couldn't put a patient on the ventilator because we didn't have an extra one. Unfortunately, we were never forced to be in that situation, but it was a concern early on with this. And so there was a lot of discussions about that and how to be fair about it. I think there's similar discussions going on about vaccine, making sure that vulnerable populations get it and that it's done in an equitable fashion. So there's some real good that has come out of this because it has forced these conversations across this entire nation.
So finally, where do we stand? Of course, what is the current state of the virus in our respective areas? Where does the treatment stand? Where does the vaccine rollout stand? And we'll start with you, James.
Yeah, so in our rural area, it's great to see, and I track this for all the surrounding counties. So we look at Potter, Tioga, Bradford, Lycoming, and then Chemung and Steuben to the north. It's trending in the right direction. Positive cases are going down. We do have an abundance of testing. We have rapid testing capabilities now that are helping with some of those travel requirements in the various states. So it's good to see that the numbers are trending in the right direction. I think as the weather starts to continue to warm up, that was one of the reasons we were spared early on in this virus. The rural nature of where we live, we're not forced together in close environments like people in larger cities are. We don't have huge mass transit busing systems and subways and things like that. People up in these rural counties, they like their privacy. They like to have their outdoor, backyard barbecues with their friends and neighbors, but we're not all sitting around in close environments. We don't have huge apartment complexes like they do in New York City with, thousands and thousands of residents. So as the weather continues to warm up, I think we'll see the cases continuing to decline. And it's great to see that, because in these rural communities, when the mortality rate ticks up as it has in our surrounding counties, everybody now knows somebody that was affected by this, and everybody knows somebody that had a very bad outcome and is no longer with us. And that's really challenging for small rural communities when you see friends and neighbors and people you went to school with succumb to the virus, or even some of the long-term effects still associated with this, the COVID long haulers, as we call them in Pennsylvania. It's very challenging because they are your friends, they are your neighbors, and it really hits home. So it's great to see the numbers moving in that direction. And I'm pretty confident they're going to continue that way. Our modeling predictions show us continuing to trend down as the weather warms up.
So I think it's about vaccination. And both of my colleagues here have emphasized that this is a safe and effective vaccine. We've 110 million vaccine doses across the country so far, but that's still only talking about, a quarter of the population or so, if you talk about how many have been fully vaccinated. So we're making progress. It's moving quicker than it was in January, but that has got to continue. So I agree with Jim. The rates are likely to continue to go down as the weather gets nicer. We do have to think about the variants and that they are a concern. And so we need to increase the vaccination now. And so we need to get that distribution. We need to encourage people when it's available to them to take whatever vaccine is first available. But I do think that's what's going to be important. That is the tool that we have. And I don't think any of our scientific advisors would suggest otherwise. That's what we need to do to make on the next step here.
Yeah, I think Mike made great points, and absolutely the vaccines are what's going to help us get out of this as a nation. I do still have concerns that English variant is in New York State, and right now it's a race, what's going to spread first. And at this point, it doesn't look like the English variant is winning out, but it's a concern for me. And although our numbers have come down, they've sort of plateaued at this point. They haven't gone down to the low rates that we had in the summer. In the summer, there was nobody in the hospital who had COVID. Now we have 2 in the ICU. So it is real. People need to take it seriously and not go out and socialize and do risky things before they've been vaccinated.
That's a great point. That vigilance has to persist as much as we'd all like it to go away.
Yeah, I can't emphasize that enough. We hear it all the time, as the numbers go down. I see a lot, just going out to the stores as we do. Masks are coming off now. When you go into the larger grocery stores, you're in Tops, you're in Weiss, you're in Walmart. A lot of people are not masking as they were in the height of this, when we were getting hundreds and hundreds of cases, even up in the thousands per month. So that's something we can't reiterate enough, and all the viewers need to follow these protocols very closely. There is a light at the end of the tunnel. I say that all the time when I talk about this. We can see the light now. Mike, you hit the nail on the head. Ken, you as well. The vaccine is gonna carry us through the finish line. But I think we heard Dr. Fauci say it a few weeks ago. You don't spike the ball on the 5-yard line. We got to go all the way through into the end zone. Nobody takes their helmet off when they're on the 5-yard line and say, "Oh, we're close enough. I'm not going to get hit hard." We still need to have those protective measures in place. Masking, social distancing, hand washing, they work.
I would like to see everybody have the option to get a vaccine before May 1st. I would love to see it happen on April 5th or April 1st or sometime really soon, because as we see in the videos, it's young people who are out there not being careful, and they're bringing back that virus to their elders, and it's not it's not a good situation. So if we can vaccinate all the kids too, that would make me happy. So at least those over 16, let's put it that way.
All right. Ken, Jim, and Michael, thank you so much for joining us today for this very special edition of State of the Virus. And of course, viewers, we're going to continue to have more episodes of this. We're going to continue to cover this virus because like I said a couple times already, it's not over yet. There's a lot of work to do. So again, all three of you, thank you for joining me and have a good night.
Yeah, thank you, George.